Welcome to The Explainer. In this clinical briefing, we're going to dive deep into the connections between asthma and allergy with a special focus on something that we might overlook in our patients, their diet.
So let's just start with a question to frame our whole discussion. Think about your own practice for a second. In those really tough, difficult-to-treat asthma cases, how often are you digging into food as a potential trigger? The evidence we're seeing suggests it's probably more critical than we think.
And here's a number that really makes you stop and think. We now know that children with a food allergy are 4 times, that's right, 4 times, more likely to also have asthma. Now, this isn't just some random overlap, it's a huge clinical signal. So let's start by looking at the common ground between these two conditions.
Yeah, that strong correlation is definitely not a coincidence. It's actually rooted in a shared biological pathway that really ties these conditions together.
And honestly, we see this connection in the clinic all the time, right? The data is pretty staggering. Nearly 80% of our patients with asthma also have allergic rhinitis. So we're not talking about two separate problems here. This is what we call a unified airway disease.
So what's the link? What's at the core of both allergic rhinitis and allergic asthma? Well, it's a specific inflammatory pathway known as type 2 inflammation. This whole process is mainly driven by T helper 2 cells, and it's the central mechanism we really need to understand.
This slide just lays out the fundamental allergic cascade perfectly. It all begins with that first exposure, or sensitization, where plasma cells start churning out IgE. You can think of this IgE as basically priming the mast cells. It's like loading a trigger. Then, when the patient is re-exposed, the allergen links up with that IgE, and boom, the mast cells degranulate, releasing a flood of histamine and other inflammatory mediators. That's what's driving the bronchoconstriction, the mucus, and the inflammation that we're trying to treat.
Okay, so that's the underlying biology. But how does this actually show up in our patients day to day? Well, this is where understanding asthma phenotypes and the specific biomarkers for each becomes absolutely essential for treatment.
You can really break asthma down into 2 big buckets. On one side, you've got allergic asthma. That's the most common type we see, driven by classic atopy, high IgE. But on the other side, you've got the non-allergic phenotypes, like late-onset eosinophilic asthma. These can actually be more severe, more resistant to steroids, even when the IgE levels are low.
Now, this table is fantastic. It's basically a roadmap for precision medicine in asthma. By combining biomarkers, things like blood eosinophils, exhaled nitric oxide or FeNO, and bromotyrosine, which marks the eosinophil activation, we can really pinpoint a patient's specific inflammatory profile, their endotype. So for instance, look at that top row. If you see high levels across the board, that screams T2 high asthma. That patient is very likely to respond well to inhaled corticosteroids. Now contrast that with the bottom row, a non-T2 profile. For that patient, ICS might not be the best first step. This is what tailored medicine looks like in practice.
Okay, so let's circle all the way back to our initial question and really focus on the role of food allergies. This is a critical factor, and frankly, a dangerously underestimated one in patients who have severe or difficult-to-treat asthma.
And listen, the GINA guidelines could not be clearer on this point. For our patients who have both a food allergy and asthma, this connection isn't just about managing symptoms. It's a significant risk factor for mortality. It's that serious. A perfect clinical example of this is oral allergies syndrome. You've probably seen this. A patient with a known birch pollen allergy eats a raw apple, and suddenly their mouth and throat are itchy. It's happening because of protein similarities between the two. The symptoms are usually mild, but it's a perfect illustration of how a respiratory sensitization can lead directly to reactions from food.
So the bottom line here is that the respiratory system can be a direct target in a food allergy reaction. Things like wheezing, that feeling of throat tightness, or a persistent dry cough after eating, all of those should put food allergy right on our differential diagnosis for any patient with uncontrolled asthma. So let's put all of this science together. How do we translate this into a practical management framework we can actually use in the clinic?
Okay, first and foremost, a really crucial word of caution straight from the GINA guidelines. We have to avoid recommending broad speculative elimination diets. Food avoidance should only be on the table after a specific allergy has been confirmed with proper testing. We're talking skin prick tests, specific IgE blood work, or a supervised oral food challenge.
For our most severe patients, this systematic, phenotype-driven algorithm is really the standard of care now. You start by confirming that it is truly severe asthma. Then, you phenotype the patient using their biomarkers.
That allows you to select the right biologic therapy, and then, and this is critical, you reevaluate their response after 4 to 6 months.
And this table gives us a great summary of our current biologic toolkit. You have omalizumab, which targets IgE, making it perfect for that classic allergic phenotype. Then you've got mepolizumab and benralizumab, which go after the IL-5 pathway, ideal for eosinophilic asthma. Dupilumab hits both IL-4 and IL-13. And then there's tezepelumab, which works further upstream on TSLP, giving it broader activity. The key here is that our choice of which agent to use is driven entirely by the patient's specific biomarker profile.
Which really brings us to our final and most important point. Phenotyping isn't just some academic exercise anymore. It is the absolute cornerstone of modern, personalized asthma care. By looking past the symptoms to the underlying biology, and by not forgetting the critical role of potential food triggers, we can truly customize our therapies and, fundamentally change the lives of our most challenging patients.